Good morning, everybody. Um, Thank you, everybody, for joining. In the interest of time, I'm not going to do a big intro. I'll leave that to Clement, our MC. I think we should start, and as people come in, we'll just let them in and we just carry on. Clement, over to you.
Thank you. Thank you very much. Good morning, everyone. Thank you so much for finding time to join us for this important discussion on how medical aid schemes can and should contribute to the success of the national health insurance once that is implemented. My name is Clement Manyatela. I'm the host of the Clement Manyatela Show on 702. I also anchor the lead on ENCA, and I'm really glad to be your facilitator for this session. Firstly, I'd like to confirm if you guys can hear me. Is everything good? You can hear, you can see me. If that is the case, then we'll just go straight into it. We all know that the national health insurance will disrupt the private healthcare system. The idea is that the funds may be redirected into the public health sector. Some may argue that it's an inefficient public health sector. The NHI bill indicates that this fund will be under the governance of the health minister, which is seen by many stakeholders in the industry as problematic. There's already a trust deficit between South Africans and the government, and just the public entities and the corruption that's been taking place. You've just seen in the past year, during this global pandemic, the kind of reports that have been coming out of corruption, the stories that have been exposed. So I'm sure you agree with me that the concerns that people have around this initiative and the state's capability to deliver is justified. A lot of things have to be fixed, obviously, including the public health system, before we can see the NHI being implemented in an efficient manner. Government has set the target by 2026 to implement the NHI. It's an ambitious target. There is no doubt that COVID-19 has affected the work towards that target, and I'm glad that Dr. Nicholas Crisp is going to help us understand where the process is right now. There are complex healthcare reforms that need to take place, and when you even look at international examples, they show that the national health systems, even around the world, would have taken more, right? Not less than 10 years to implement. And many who pushed ahead despite this suffered some severe negative consequences. So with this in mind, our aim today is to engage in a discussion with our guests, the industry leading experts on this issue, so we understand their views on the implementation of the proposal and what's going to happen and what should happen so that the NHI is implemented in a manner that satisfies all the stakeholders. But before we start, let me bring your attention to a few housekeeping rules. You can just bring in your questions. What I'll do is conduct a short Q&A session with each speaker. So if you have any questions throughout the conversation, you're welcome to write in the chat. I'll be monitoring the chat to make sure that I get your questions and put them to our speakers today. And if you want to share what is being shared here on this webinar on social media, you're also welcome to do so. The hashtag is hashtag Profmed NHI Webinar 2021. That's hashtag Profmed NHI Webinar 2021. So let's begin by introducing the guests that are going to join us and give us their thoughts on the NHI, how far the implementation is, and how that is going to be affecting the private sector. We've got Craig Comrie, who is the CEO of Profmed Medical Scheme. Thank you, Craig. Dr. Angelique Coetzee is also joining us. That's the chairperson of the South African Medical Association. Thank you, Dr. Coetzee. Dr. Nicholas Crisp, who's the Deputy Director General at the Department of Health and someone who has been involved extensively with the implementation of the NHI, is also here joining us. Thank you, Dr. Crisp. We've got Daisy Siakwe, who is the General Manager of Health Funders Association. They've had some thoughts on this NHI proposal and its implementation. So thank you, Daisy, for also making time. So we're going to start with Craig, who's going to be our first speaker. And I'm going to hand over to you, Craig. We are talking here about something that is so huge, that is so complex, that has consequences for medical aid schemes, for your members as Profmed. And I think the central issue is the future role of private healthcare and medical schemes once the NHI is implemented. As the CEO of Profmed, how do you think this will impact medical schemes?
Yeah, thanks, Clement. There's no doubt that NHI will have far-reaching implications, and they need to be far-reaching. And so we do not shy away from the conversation of how we believe NHI should actually work. We fundamentally believe medical schemes play such an important role in terms of the success of NHI. And so I just wanted to create the perspective in terms of where, or the context in terms of where some of my thoughts are. So I'll provide some general comments and then specific comments to the role of medical schemes within NHI. Profmed looks after 36,000 professionals and their families. So schemes are community-based. So it's a group of doctors that got together originally and established a medical scheme to take care of their healthcare needs. And so a lot of the comments come from that context in terms of how we can contribute to NHI, but also how some of the uncertainties that come through any change have impacted the professionals in South Africa. So I wanted to just start off with some general comments, which really talks about the fact that change is necessary. We see the imbalance in terms of our healthcare is distributed in South Africa. That has to change in some way moving forward. The comment that affordability is always a concern within private sector is absolutely right. It's something that globally we see as a huge challenge as new technologies come about. Probably as burdens of disease get worse within different societies, and mostly due to behavioral changes, the fact that people are living sedentary lives, sitting behind desks and not really being out and exercising is an issue. But we see those impacts through our chronic disease populations, and that places even additional burdens throughout the world on healthcare systems. I think one thing we acknowledge in an absolute manner is the contribution and the connection between healthcare and the economic future of South Africa. There's two bits of research that come out. One that says out of everybody who's gone bankrupt in the last 5 years, 67% is due to the cost of a health event within those families. The other interesting thing relating specifically to professionals is that professionals are one of the largest employers in any economy. They employ from 3 to 15 staff on average. And so as we look at the professionals within the country, we really need to be generating more professionals, and in that we'll find some answer to the unemployment rates within the country. So there's no doubt that the cost of private healthcare and even the cost of medical schemes is high. We see in the public sector, perhaps that's seen as low quality, and there are centers of excellence in the public sector, which we mustn't ignore either. So it's not just generalized low quality. I think access is a problem throughout the country in terms of healthcare. So we see a partnership approach in terms of private and public sector in removing the inefficiencies in both of those spaces to create a better healthcare system in future. And so national health insurance, and the debate has to be around how we pull in all the different stakeholders to actually work together for a better healthcare process in the future. I think what we must avoid is the political posturing, and we're seeing that every few years. But we must get to the pragmatic spaces. I think often the analogy is maybe the policy is the rails of a ladder, but the rungs still need to be carefully researched and established by the the healthcare stakeholders within the sector. And so we do need some pragmatic and some clearly thought out and well-positioned ways forward to implement an NHI in the future. And there are some foundational shifts and some things that we've learned from in terms of COVID that mean that we can work together and for the better of South Africa. So I think those are just important general comments that I wanted to make. And the next part, I wanted to speak and address specifically NHI and the medical scheme environment. So as we look at NHI systems across the world, things like even the NHS system in the UK is accompanied by 10% of private healthcare insurance that actually supplement the NHS in the UK, providing choice to people who can afford to purchase healthcare as well. Medical schemes were positioned many years ago to remove the obligation on government to provide that healthcare benefit. In fact, at the moment, we see 8 million South Africans covered by medical schemes. It's around 15%. Is there another 2 million who actually can afford medical schemes who choose to pay as you go as well? And so we see that there's about 220 billion rand spent in the private sector, and mostly from the medical schemes in terms of providing healthcare to people who seek it. And no doubt who pay for it and pay lots of money for it. And so the search for value is something that the private sector has to make sure we corner going forward. So maybe 2 points in terms of how medical schemes fit into the future of NHI. So we've seen the policy documents. In fact, we've commented on NHI policy documents since late 2000. In fact, I saw Profmed's comments started in 2007. And as recently as this year as well. What we see, the space of a medical scheme still being there for the foreseeable future is where it comes to the fact that NHI, from a budgetary perspective, will be able to cover probably a smaller range of benefits at the start, and in the very long term, a far more comprehensive set of benefits. In the interim, what is called complementary services that medical schemes offer is probably going to be the bulk of benefits currently. And so we see for the next 10 to 15 years, and hopefully we'll hear Dr. Crisp's view on that, but medical schemes will play a crucial role, certainly for the foreseeable future. I think one of the other points I need to make is one of the key assets within the healthcare system that we need to focus on is those professional healthcare practitioners. And I'm going to share a little bit of information that concerns Profmed as we try and secure these assets for the future. I think one of the plans that is missing within the NHI plan is a clear plan on how to create security around income and security around the future of healthcare practitioners. We realize that in every sector, the most important sector worldwide, that's becoming where there's a global imbalance and demand for professionals is the healthcare environment, and specifically in the doctors and specialists arena. And we've seen that impact within the Profmed concern. So we do think that a successful NHI relies on medical schemes to still play a very important role, but I know there are other speakers that will cover that in a little more detail. That would mean that one of the focus areas has to be that we produce more healthcare specialists and doctors, and that we have a clearly articulated plan in how to retain them. So I wanted to share this just in terms of the professional healthcare workers. So these are doctors and specialists. Within Profmed, out of the 36,000 professionals, 20,000 of them are healthcare professionals, and probably 80% doctors and specialists. And what I wanted to share, the real problem that we've seen is that if South Africa produces about 1,600, and maybe with the initiative to train doctors in Cuba as well, that might move up to about 2,000 doctors. Only within Profmed, we have tracked over the last 5 years that we are losing in the region of around 260 doctors a year on average. The pinkish line, in fact, shows you the number of professionals we are losing to immigration. So when somebody leaves Profmed, we phone them and we ask them, and these are people who voluntarily provide us with reasons on why they're leaving Profmed. And so we've seen the number one reason for people to leave Profmed is immigration. Certainly not leaving for other schemes, not because of affordability, but immigration. And so we have to preserve and try and get and retain these professionals. Interesting, the bluish turquoise line at the bottom gives you a view, and a very clear view from 2020 and 21, which is a projected view in terms of the deceased line. So you can see the real impact of COVID coming through in our experience in terms of the other reason why people leave Profmed. Certainly has got some roots in the COVID experience. Here's the next graph also just shows another space which gives you then how many of the people even are in fact healthcare professionals. So how many are they doctors and specialists? These are the actual numbers that we've got. So you'll see quite an increase over time, a little downward trend in 2020, probably because of lockdown, and then an upswing again in 2021. Where we project about 282. These are doctors and specialists that we'll lose in the country. So it's just pointing towards the fact that we need a plan to retain these very important assets in the country. And we can't afford to leave that gap in the policy of NHI. And as we reform NHI, we need to secure these assets. I want you to then just, and I think Dr. Crisp would be interested in some of these numbers, but Profmed vaccinations up until, I think it's earlier this week, is around 22,000. So of our members eligible for vaccines, which are probably in the region of 45,000, we just under half have received the vaccine. But I think if there are anybody that doubts the efficacy of the vaccines, the next slide will actually or provide you some information of the Profmed experience in terms of why you should get the vaccine. So effectively, what we're showing you is our January to July experience, and accepted that the vaccine process hadn't been launched early on. But we measured the hospital admissions. So you'll see 2,882 hospital admissions for Profmed members this year. Of that, these are in fact admissions. These are COVID-related admissions only. It's not all our admissions. It's COVID-related admissions to hospital. Of that, 2,609 weren't vaccinated. We then looked at how many were vaccinated. So we saw 141 that had received one vaccine. And we haven't distinguished between a J&J and a Pfizer vaccine here. And then 132 who were actually fully vaccinated. Then we looked at how many landed up on ICU and higher care. And this is where the number starts to prove the value of vaccines. So 338 of the 345 patients that landed up in ICU, most on ventilation, were unvaccinated. 7 had received one vaccine, but none who had received both vaccines. I mean, it's a clear indication for us on the value of how to fight severe infections in terms of COVID-19. And we'll keep on updating these stats and watching this quite carefully. But I thought I'd end with just that indication in terms of how the vaccines have worked. But it sets the platform to promote preventative care, primary care benefits, and we believe that should be the basis upon which the NHI implementation program and benefits should be launched as well. So I'm going to close off with that, and thank you very much. Clement, I'll hand it back to you.
Well, thank you very much, Craig, and thanks for giving us those numbers, just demonstrating the value of vaccines. Most people that are on ventilation are not vaccinated. I think it's important that we revisit and we broadly share this data, so we also help government with people that are still asking questions around the value and the necessity of being vaccinated. So thank you so much, Craig, for sharing that. I want to pick up on a point you raised around your members. You indicated we're talking 36,000 professionals that you represent and their families. whose career trajectory could be altered by the proposed restrictions on how individuals may soon be able to access private healthcare services in South Africa. I know as Profmed, and you've shared some of the data with us now, that you've looked at around 260 doctors and specialists emigrating each year. That missing part that you spoke about, what has been your contribution and your input and proposals? Because the missing part is that aspect in the NHI on the plan to halt the exit of these professionals, right, and generate more healthcare workers. What have been your proposals as Profmed?
Yeah, in our document that we submitted to the Health Portfolio Committee, our submission includes a clear plan in terms of how we can retain them. And one of those is relating to the security of income. We need to give doctors an indication that they aren't going to lose their professional status or their independence as doctors moving forward in an NHI scenario. There's no doubt that there's a possibility that public sector patients or those that are uncovered will be allocated to these GPs and specialists in terms of NHI. So the volumes will probably offset any potential loss of income, but we must place that at the forefront of securing their services going forward. It's almost creating a prospectus for doctors and specialists on how they would work within an NHI environment. And so as there are many looking forward to NHI, we see almost an equivalent amount that actually see NHI as a threat to their futures in terms of their income or the way that they produce income. The fact is we need to take them through a change process where we provide some levels of security around that future. And it's probably one of those missing rungs in terms of how we develop the overall NHI policy and implement it in the end. And so we feel the industry, those same professionals have to also contribute to developing how that will work in the future.
Yeah, Craig, thank you. I think some of the questions coming through, I'll put them to you at the end of the other presentations. Let's bring in Dr. Nicholas Crisp now, who is one person that is no stranger to the NHI. Dr. Crisp, you are passionate about NHI, the implementation of this system. You were, in fact, brought into the department to assist with implementation. But the biggest focus has really been on the global pandemic. How has this affected the NHI implementation, and where are we now with that process of implementation?
Yeah, good morning, Clement. Good morning to the viewers of the webinar and participants. First of all, let me just say that the NHI is not the boogeyman that everybody is making it out to be. And I'm going to try and, in a few minutes, try and explain the basic tenets and what we are trying to achieve with NHI. But I'll respond to your question first by saying that COVID-19 has been the biggest wake-up call that health systems around the world has ever had. What we've seen is systems that are national systems that have proper primary healthcare structures and are able to refer and move patients quickly have survived or have fared best. And those that have had proper public health systems that are able to mobilize vaccination programs quickly have done better than those that don't have that capacity. We've done pretty well in South Africa, and it's been a pleasure. I've been in the department now 3 months, and in that time, I've basically only worked on the COVID rollout, except for occasional weekends on NHI. And it has been a pleasure working with most of the private sector players who've come to the party and really try and share data, share the way we do things, plan together, and so forth. And that's the spirit in which we will build a new future. But if I may, I want to talk about what is national health insurance in a few basic points. Clearly, it's complicated, so in 15 minutes or so, one can't do it entire justice. But national health insurance is a financing mechanism. So clearly, that's why the medical schemes are more concerned about it generally than the providers. So the design at a macro level, if one reads the health economics and the WHO's writings on health systems, we are aiming for a single payer system. Now, no single payer system ever is single. We heard Craig referring to the National Health Service in the UK, where up to 10% of payments are made and administered outside of the NHS, that's fine. That's 10%. That's not 50% like it is in South Africa. And that's in a relatively equitable population, not one like ours, where we have massive disparities and the world's worst Gini coefficient. So why do we need a national health insurance? Well, because our health system is in a mess. We have by far the worst outcomes for our health, for our inputs of all countries in the world. We find ourselves in the top 30 economies of the world, but with health outcomes amongst the poorest, even worse than some of our neighbors who are obviously not very wealthy countries in Africa. And why that is because we spend our money badly. We don't integrate what we are doing, and we have concentrations of good healthcare in very few places and a lot of poorer healthcare in between. So how do we get to where we are going? First of all, we need to understand that this is a big reform we are talking about. This is not fiddling with the edges and saying, well, we think that medical aid should change this policy or that policy, or the government should do this or fix a hospital. We're talking about fundamental reform of the health sector. And what we want to end up with is where the only reason why you will get healthcare is because you need it. We can't have a situation where we've heard a moment ago where people go bankrupt regularly or get dumped in the public service because they run out of a medical scheme or they run out of their savings. They have to sell their house and their car and mobilize their families to try and get healthcare. That is in nobody's interest whatsoever. We also need to make sure that if we are going to build an economy, we need healthy, educated people. And if you are hungry and you are have ill health, there's no ways you're going to contribute to the economy. So how do we get there? The answer is incrementally, in stages, but to a defined plan. And the idea is that we will have a purchaser-provider split, and people don't like that word either. It means the purchaser will primarily, and nobody has ever said exclusively, but primarily be the fund. And we'll talk about where the money comes from and how much it is in a moment. And the providers will be public and private providers. To Craig's point he made a moment ago, the private providers are critical because they constitute in some specialties up to 90% of the total available specialists. Certainly in oral health, the concentration is hugely in the private sector, which means that those people's skills are not available to large numbers of people who would benefit from them. We also have a situation where, in order to fill the space, professionals do work that is not really their scope of practice. So we have specialists doing GPs work, GPs doing nurses work, nurses doing community health workers work, and it generally in an inefficient environment. We have a very complicated public service, which people don't really, in the private sector, don't really understand. We have 10 departments of health, all autonomous of one another. There's no such thing as a health budget in the public sector. It's just an agglomeration or an additive of 9 provincial budgets. They don't get given money for health. They get given money for the province, called the provincial equitable share. And then the provincial governments allocate money to health and education and their other functions. So it is extremely difficult for cohesion, even in the public sector, and to move patients between provinces because that money is basically allocated for the population of the province. So that's problem number one in our structural design. On the other side, on the financing, we have more than 74, or at least 74 medical schemes with a whole lot of different packages. We're all aware of these, hospital packages, comprehensive packages of various descriptions that are very complicated to follow. Even the brokers get it wrong quite a lot of the time, and they are supposed to be trained in these things. Every one of those 74 medical schemes must have its own trustees. They have actuaries who do their work, administrators, and the knock-on down into practices where people must have administrative capacity to work out whether patients do or don't have cover, etc., etc. It's extremely complicated, and it has to be bought, this healthcare in the private sector, from the hospital, separately from the doctor, separately from the lab, separately from the radiologists, and so forth. It's very, very inefficient. Even if some of the healthcare is extremely good and competes with the best in the world, it is undermined by the systemic problems that we face. So we have a messy system. It is disjointed. It's duplicative because we all end up doing a lot of laboratory tests and x-rays over and over again. And we lose the continuity, especially of patients who have chronic care. So we will get there in bite-sized chunks, primarily starting with the primary healthcare environment, where we are looking at funding what are called contracting units for primary healthcare using a capitation system. That has lots and lots of options to it, and we need flexibility, which is what we are trying to design in now. But what is important is the money gets allocated to a designated community, and the players in that community are then engaged as a collective to provide the necessary care, the primary health care, to all of those patients. So the role of the GP is very important in there, and Angelique knows exactly what I'm referring to. And the role of the nurse, the pharmacist, and everybody, including the community health workers, is huge. And we have seen the provinces who've done well during COVID are those that have large numbers of community health workers going door to door and implementing preventive programs. So I'm happy to go back to that if we have time. When is the right time to do this? The right time would have been 25 years ago. There's never a right time. Minister Bevan, after the Second World War, made an announcement after a big fight in Parliament. The NHS starts on Friday. And then they pan the shot in the movie, and there's London major hospitals lying in rubble on the streets. And so far, they started the NHI on Friday. So there's never a right time, and you don't have to fix the whole public health service before you can implement the national health insurance. You have to fix everything, and you've got to do it bit by bit and tidy the things that are wasteful, duplicative, and really don't make sense. Can we afford it? Obviously, the national health insurance is about financing. So we spend 8.5% of our GDP on healthcare, 8.5% of the 30th biggest economy in the world. And I saw our figures were adjusted upwards by 11% last week. So it might even be bigger than the 30th biggest economy in the world. 8.5% of GDP is more than most countries spend. Where's it going? Why are we getting such poor outcomes? Because we waste so much on duplication and on doing things that don't need to be done. It's systemic reasons. I'm not accusing an individual of anything. It's just that is how it works. So we need to take the 250 billion that is in the public sector and bring it into one space, not 10 different governments with conditional grants and equitable shares and so on. All of it. That will be threatening to provincial governments, of course, because it's almost a third of their budgets that they control at that level. But it's the only way to do it. And the same kind of pain is going to happen in the private sector. Instead of making voluntary contributions, which are a form of tax, they just voluntary tax, but they're still tax. And we need to make it that we raise those revenues through tax, not as well as the medical scheme contributions, but instead of. So if I, for instance, pay 5,000 Rand a month to a medical scheme, just figuratively, I should pay 4,000 Rand to the NHI and nothing to a medical scheme unless I want to cover something that's not covered by the National Health Insurance. And as Craig said in the beginning, and in a transitional period, that is likely to happen. But by the time we implement a proper health system where all the providers, public and private, are accredited and are providing services to everyone, it slowly but surely balances out that people have confidence and find, I don't need to have medical aid except if I've got something very specific I want to cover that is outside of the framework of the benefits of the NHI. So there are key words here. One is incremental. Two is that there will be a transition period. And I don't want to be pinned to whether it'll be on Friday, the 30th of October, 2026, or when are you going to switch on, because it doesn't work like that. The NHI will start to switch on at the end of this year. Some things will change, but everything won't change next year. Small things will start to change. Systems get put in place. Patient records start coming right. The EVDS that we see at the moment is built on the NHI's HPRS platform, the Health Patient Registration Platform, and the data that is used for all the monitoring and management of vaccinations at the moment is the same platform that will be used for the patient records. So we have had experience now of building patient records around vaccination, and there's no need for practitioners to scrap their patient records. What they need is interoperability with the system. We need proper definitions and so forth. So there's a transition period. Craig mentioned the word complementary. It's complementary. It's whatever the NHI is not going to cover and will declare we are not covering X. Then the bill provides that the medical schemes, even at the end of the process, when a large number of benefits are provided in the paid for in the NHI and provided by the public and private accredited providers, will be can be covered by complementary. And there have been lots of comments in the health market inquiry about these inefficiencies, improvements that need to be made both on the public and the private sector. And although that was a report in the private sector, there are lessons for the public sector in better regulation, better leadership, and formulation of better systems, which we are busy with at the moment. In the end, what we want is solidarity, where my health matters to you as much as your health matters to me, which is what we've learned in COVID. We need equity. We can't have a situation that because I don't live on the doorsteps of Steve Biko or one of the Mediclinic hospitals, it's difficult for me to get healthcare, if ever. It's just not acceptable. If I'm a woman and I have breast cancer and I live in northern Vembe somewhere, there's no reason why I should not be treated properly for that breast cancer. But at the moment, I'm excluded because I live far away, I don't have resources, I can't afford to pay for it, and so we don't have proper referral patterns and et cetera, et cetera. So equity is a big issue. The other one is universal. And we hear a lot of colleagues presenting in Parliament at the moment on universal, and they talk about universal as two universes. There's only one universe in universal. So my end statement that I want to make, because I see time is marching on, is we need this as citizens. We need to have a system that we all can share in so that everybody can get proper health care. I believe that we do have the resources. It's sad to me when people emigrate, but what Craig wasn't telling us is how many immigrated into the country. And our examples of what we collect is actually there are a lot of professionals who immigrate to South Africa to come and work here, including health practitioners. So I don't think this is a boogeyman at all. I wouldn't work with it if I didn't think so. I do think we need to understand the facts before we get too despondent or excited about things that we think might be threatening. And we need to take hands at South Africans and fix this health system that's really not going well. Thank you.
Yeah, thank you very much. I see our time is really not our side. So I'm just going to ask one question, Dr. Crisp, and then I'll move to Dr. Angelique Coetzee. You've spoken about fixing the system. How do you fix the system? Because to your admission, the system is in a mess right now. You need to gain the confidence of the public. You said that there are a number of things that you can learn from the private sector. Yes, both need fixing, private and public, but you said better regulation, better leadership. But as it stands right now, can you confidently say that there is some fixing happening in government, in the public health system, so there's better leadership, so there's better regulation, so that the system is not a mess, so that there is confidence of the general public in the entirety of the system itself?
Yeah, yes, of course. Otherwise, I mean, I wouldn't have been pulled out of retirement if there wasn't a seriousness and colleagues that are joining me forming the nuclear office for a start in provinces. It's not about only fixing the public sector. It's about the public sector and the private sector using the space. And we have many examples. During COVID now, we spent a lot of time building service level agreements to work together where both the public sector and the private sector have exchanged patients in different places to look after one another. In cancer therapy, we have lots of problems in the public sector with insufficient capacity, and there's spare capacity in the private sector. Working together, I've had many meetings with hospital groups, and there's no reason why we can't work together to use that capacity. We work together with the GPs on many things. Now during COVID, we've been working very closely with the pharmacy groups and the independent pharmacists. There's a long list of improvements in the system that are going on. But not everything can be fixed all at the same time, especially not during a third wave. And with a lot of us being quite tired at the moment with long hours on the COVID response. But make no mistake, there's plenty that is going on together. I want to emphasize, it's not an either or. The private sector also needs to get their house in order. And we will see a reduction in the number of medical schemes as one of the initiatives that's going to happen for that space. But I'll leave it there. Thank you.
Yeah, thank you, Dr. Chris. But let's move to Dr. Angelique Coetzee now. Dr. Coetzee, a number of doctors have indicated that the focus needs to first be on fixing the public sector to a point where it can be appealing to private sector patients. What are your feelings as SAMA? I know you've been questioning how feasible government's plan is to cover at least 90% of South Africa through the NHI by 2025. Obviously, there's still much that needs to be realized, that Dr. Chris says. But are you confident that government is capable to run the system?
Good morning, and good morning to all the viewers and listeners, and to my colleagues here on the panel. Thank you again for asking us our opinion. Are we confident? Not for 2026. It's not going to happen. And the reason why I am saying, and what I based it on, is the fact that we have now seen with the COVID-19, just only try to get the general practitioners on board to become vaccination sites. We haven't even, I think there's less than 5 private general practitioners that got it right, because the difficulty to become part of the master's list, as well as to get yourself onto the EVDS system, is just mind-boggling. It's nearly 6 months later and we haven't fixed that yet. So if I only look at that, it's going to be extremely difficult. So I need to say again that SAMA is the biggest medical doctor association, with our members in the public as well as private sector. SAMA had been part of the Green Paper up until the NHI bill in 2019. We have commented, and what we have seen is the challenges of the health system regarding public health sector, where we see that the quality failings in delivery and infrastructure. We have seen the human resources shortage, the maldistribution as well of these shortages, acute shortages of management skills, poor access to healthcare, physical services not available, financial constraints, as well as provinces failing to address their own challenges, as Nicholas already alerted to. So if you look at the private sector, again, widespread failures in regulation. There's expensive and financial risk exposure to all our users out there. Quality is essentially unmeasured. Fraud, waste and abuse, fragmented delivery of funding, clinical governance, all of that is addressed. And even it was mentioned by the health commissioner impact that studies that have been done. They highlighted to us from the competitions commissioner. They highlighted that there's a lot of multi-market failures, again, both from provider and funder perspective. But it doesn't seem to us that the recommendations from the HMI for improving the existing healthcare sector as in preparation for the implementation of the NHI is currently being pursued by the National Department of Health, which is a pity. So then if you look at the regulations enabled by the bill, some of the aspects to be regulated is the payment mechanisms for the providers. That's going to be a problem. Fees payable by users, optional contracting of private providers, relationship between the public and private establishments. It's a huge problem currently, especially on provincial level. The clinical info and the diagnostics codes to be used. We don't know what's happening to the coding. We need to have an in-depth analysis of coding going forward and who is it going to belong to in the end of the day. Accreditation mechanisms, the Office of Health Standards. It seems to us that if you look at the con, everything has been thrown over to the Office of Health Standards. The functions and powers of the district health management might be a problem. Relationships between the fund and the Office of Health Standards again. So, and then the monitoring and evaluation of the fund. Sorry, I'm just rushing because of the time. So if you look at the role of the medical schemes, the NHI bill currently states that when the system is fully implemented, medical schemes will not be able to provide cover for services that are paid for by the NHI. So if we look at that, this is one of our biggest questions. Clarity is required on the services that private providers can undertake, thus outlining the role of the medical schemes. In the UK, citizens are allowed to take up additional cover for specific treatments that are covered by private funders. Canada, Medicare covers most essential services, and there's hardly any room for private funders. Clarity on this issue cannot be overemphasized. Currently, it's broadly stated that any procedure that is not covered by the NHI, we don't know what, if it's not covered, who's going to be able to fund that, the costs there. So if we then, again, one of our big concerns here is that, it's correct that what Nicholas Chris said, it is a funding model, but we're having this talk about the funds, but how can you put a price and discuss funding if you don't really know what you're going to fund? What is what care are you going to provide? And we know it's on primary healthcare level where we're going to start, but it's like saying, I have 5,000 Rand and I'm not going to buy a car. The problem is, what car are you going to buy, and will that 5,000 Rand be enough for that car? So we first need to look at the regulations out there that will help us to decide what we need. Then you look at the funding. But to put the funding first, it might be a problem. And then if we look at the figures that the impact that it would have on the general practitioners in the private sector, we know that in 2018, approximately 83% of South Africa were served by the public health facilities. In contrast to that, your private healthcare facilities were serving approximately 16.3% of the population. If we look at the latest general household survey, only 17 in 100 South Africans have medical insurance. Yes, so we need to have another funding model or another model on how we can provide healthcare services. But there's also that we need to look at, if you want to have this and if you want to still have your medical schemes as well, we need to look at the number of the practitioners in the private sector. We see that in 2010 there was about 6,500 specialists. That increased to 7,513 in 2014. Nationally, there are about 1.75 medical practitioners in the private sector per 1,000 insured population. Then again, if we look at that, there's a perception that there are more general practitioners in the private sector, which is not true. If you look at the figures, there are more doctors in the public sector. I'm not talking about specialists. I'm talking about general practitioners than they are in the private sector. So we need to look at that. We also need to look at the training. So whenever you want to bring in your national health insurance without good outcomes, and we all agree on that, we need to go and look, do we have the manpower? When are we going to have enough manpower? How are we going to do? How are we going to, what services and when? So you cannot take your medical schemes away if you don't even know what are you going to fund. I don't know, for example, whether they're only going to fund diabetes and where they are going, or whether they are going to fund hypertension, for example, as well. I don't know. So we are working on assumptions that whatever is under PNB will be part of National Department of Health's NHI, but we do not know that the funds will be there. But that's why we keep on saying, let us see what we're going to provide, and then look at the funds. I know that you know, if you bring in your interns. Remember, interns is also giving a service to the population. Your interns are the primary first contact, and so they are working while you don't have that in the private sector. Also want to bring it in. Yes, we should have general practitioners doing general practitioner work on the level that they are trained. We need to have more nurses around. We need to have social workers, physios, all the other services that needs to be there. But the problem is currently, who's going to fund that going forward in if the general practitioner opt to go into a contract with the National Department of Health. So there's a lot of things that's not okay, that we don't have clarity on. And if we don't have clarity, the doctors are jittery. If that, I think Craig said that they need to understand what is going to happen to them going into future, as well as all we have seen now during COVID-19, all the fraud and the insufficiencies, and how the public sector is still struggling. And don't for one moment think it is all rosy in the private sector. It's also not all rosy there. We've got lots of problems there. But if you don't go into fix that before we start, if you don't build the foundation for the home that we want in, and we want everyone to come into and be safe. If we don't have that foundation, we're not going to get anywhere. Not in my time, not in Nicola's time, not in Craig's time. Thank you.
Thank you, Dr. Kotsia. And maybe Dr. Chris, when he was talking about that transition period, I don't know how long that's going to be, but hopefully it's going to fix all of these issues and concerns you're raising. I want to quickly move to the fourth speaker, and I'm hoping when she's done, we can dedicate some time to questions. And you can keep your questions, by the way. I just put them on the chat box. I see some of them have already come through. When Daisy is done speaking, I'll put those questions to our speakers before we wrap up. Our fourth speaker is Daisy Siakwe. Daisy, you can talk to us about what your concerns have been, because when the NHI bill was introduced, the HFA said that there were some areas of concern in the bill, such as the proposed single centrally managed fund. What were you concerned specifically about that? And where are you with working with government to resolve those concerns?
Okay, thanks, Clement. You know, the HFA believes that the private health sector funding industry is a national asset, and that it should be leveraged for both during the implementation of NHI and once the system is up and running. Medical scheme industry has technologically advanced infrastructure and experience in the delivery of governance of social solidarity-based risk frame pools, efficiency risk management payments of services providers. We also
Daisy, I think we're really struggling to make up what you're saying. I think it's probably the network.
Bill.
Yeah, I think it's probably the network. I'm not sure if we can let's give it a try again, and hopefully it's going to be much better if you're able to move around.
Can I maybe switch off my camera? Maybe it will be better.
Sure.
I think it's because I'm connected with my phone, it could be bandwidth. Okay, thank you.
Let's give it another shot.
I was saying that okay, just 1 second for me. Clement, am I still in? Can you hear me?
Yes, yes, you are. Yeah, let's give it another shot with your camera off. Hopefully we'll make up what you're saying. Go ahead.
All right. I'm not gonna start from the beginning. So I was just saying that in terms of section 33 of the 2018 bill that provided for supplementary role, there has not been motivation published to support this change in the role of medical schemes, nor any technical analysis of the implication on the 9 million beneficiaries of medical schemes and the private health sector. This research suggests is used by more than 40% of South Africans when seeking healthcare services. We also understand that the purpose of the socio-economic impact assessment is to ensure that implementation risks are anticipated and that the unintended consequences are managed. The CS guidelines highlight that NHI, as a major and substantial policy proposal, requires a large research and modeling program, and yet no such assessment appears to have been undertaken. The CS publication on 2019 on NHI bill includes costing in 2010 terms, which is concerningly outdated, and also includes a number of misrepresentation of medical scheme benefits as well as healthcare costs in South Africa relative to the OECD countries. The motivation for a restriction of medical scheme to compulsory cover is therefore tenuous. It will be substantially more useful to use establishment of the NHI framework as an opportunity to improve the way that medical schemes function and to create an integrated medical scheme system capable of supporting the NHI fund in facilitating access to quality healthcare for all. And extensive work of the health market inquiry is a key reference point in this regard. We are very concerned that these recommendations have not been implemented since the final report was published in September 2019. Recommendations both refer to recommendation on this report refer to the delivery and the reimbursement of private sector as well as the operation of the medical schemes. And when it comes to the proposed single and centrally managed fund, the HFA believes that this could be presented potentially, this could present potential risk for inefficiencies, mismanagement, and corruption. We are also concerned that there seems to be a widespread misunderstanding that NHI bill means that the current medical scheme contributions will automatically be redirected to the NHI fund. This is not the case. A key concern is that, and the consequence is that medical scheme beneficiaries who currently fund their own benefits will now be drawing on state resources. And currently, these beneficiaries pay taxes and fund themselves. For assumption to assume that taxes that can be raised further to fund the cost of the benefits in addition to benefits of currently uncovered population needs to be properly interrogated and assessed. And therefore, spreading existing expenditure across everyone reduces the amount available per person and constrains the benefits that NHI can offer. There is also not there will also not be it will also be sorry there would not be the case in this will not be the case in the multi payer model, especially if the visual pooling mechanism for NHI benefits package is enhanced in the public sector funding. We believe that a multi-payer NHI model will result in better benefits and more efficient delivery of care for everyone in the population. Research has also shown clearly that there is not it's not the existence of private sector that is the cause of the lack of healthcare professionals in the health system. As Craig mentioned, we are simply not training enough personnel, and we have already lost large number of nurses and doctors to international market. We need to improve our training throughput and working condition in the public sector to retain these skills. The Presidential Health Compact has identified a number of practical and feasible action points for the social partners to work on to achieve this. Also, those who are likely to claim will be motivated to purchase cover, further destabilizing the risk pool, and ultimately leads to limited availability of top cover and more reliance on out-of-pocket expenditure, like we have seen in Ghana. In the UK, there is no legislated limitation on private cover, but the market forces take account of what services the NHS covers, and the private health insurance market responds accordingly, providing important public protection. On legislation limitation or on private insurance cover, we believe that this will lead to an actual death spiral with respect to any form of top cover. The legislated limitation means that there is a limited scope of private insurance, and the increased tax burden will also narrow the pool of people who can afford top cover. And then the HFA also has been active in participating in industry discussions on NHI, and we are passionate and committed, to support and strengthening the health system for the benefit of all. But we are concerned that the motivation to limit the role of medical schemes is underpinned by a number of misconceptions regarding how medical schemes operate. For example, it is not the case that limiting the role of medical schemes will automatically lead to a redistribution of resources between the public and the private sector. We also believe that it's not the case that medical schemes beneficiaries are predominantly white. We also, strongly believe that it is not the case that single risk pool will lead to optimal benefits for everyone, nor the NHI will enhance financial risk protection for medical scheme members. And like Dr. Chris mentioned, HFA believes that there is an opportunity to build a collaborative framework based on social solidarity, and the HMI, the Licensing Commission, and the Presidential Health Compact, which provide immediate guidelines on steps to take. The management of health expenditure and ensuring access to quality healthcare treatment is a complex challenge and a challenge that countries grapple with globally. We have built considerable expertise in the medical scheme sector, and then with strong local expertise related to our unique disease burden. And as again, Dr. Chris mentioned, there has been already precedent for work being done together in collaboration between the private and the public, where the public health experts particularly work with the private sector during the COVID-19 pandemic. And we strongly believe that and advocate, to build on this type of collaboration that has already taken place. And with that, Clement, I come to the end of my comments. Thank you.
All right, Daisy, thank you for that. We're out of time, but I want to ask some of the questions that have been put forward by some of the participants. I'll direct them to each speaker if they're clearly stated. So I think the first question we got was from Tony van Niekerk, who had a question for Dr. Crisp. And the question for you, Dr. Crisp, is there an example of an effective NHS or NHI somewhere in the world that we can copy? That's a question from Tony van Niekerk. So I'll give you an opportunity, Dr. Chris, to respond to that. Tony also sending another one saying all of this needs to happen in an environment where we have zero confidence. All of this is happening in an environment where we have zero confidence in government delivery of service, with very good reason. Until government proves delivery, this will be a pipe dream and a vision in theory. So Dr. Chris, you can respond to that question and this comment, and then I'll ask the others to the other guests before we wrap up.
Okay, thanks very much. I'll try and keep it short, but obviously there are long arguments to both of these. Tony, thanks for the questions. Can we copy from elsewhere in the world? No, because there's no other country that even vaguely has the social structure that we have. Can we copy examples from other countries that collectively contribute to what we do? Yes, indeed. Malaysia and Thailand have got pretty new national health insurance systems that work very well. Germany has got one that started in the 1800s. The UK started in 1948, and there are other examples all over the world that we have been looking at, talking to people, working with the WHO, and at the moment more than 40 countries are implementing some or other form of national health insurance or new financing mechanisms to cover universal health coverage. So indeed we can learn some things, but copy a system, that's not going to happen. Zero confidence in government, well, I now have joined government and I can only agree with you. It is extremely hard to be confident and positive all the time. But there are examples, and I work every day with people with the most unbelievable work ethic who work really hard within sometimes very difficult circumstances to make sure that people get proper health care. And I think that sitting on the outside and moaning is now not really going to help. So I think we need people to step in, make noise, shake things, complain, be as transparent as possible, and that's what I intend to do for the 4 years I've got left until I have to retire. Thanks.
Yeah, you're going to need a lot of support, even inside government, for that, Dr. Cripps. So good luck, because many of our government officials, or some of them have shown us that even when you make that noise, there's simply no interest to do what's in the best interest of South Africans. There's a clarity-seeking question here, Craig. I don't know if you can take it. That in fact came from Dr. Crisp around the research on immigration. And he wanted to know, does it show that the NHI is the cause, or is it also to do with other factors?
Yeah, the two research papers that I referenced, the BMC and both the Econex papers, only refer to the net immigration loss of healthcare practitioners to the country. When we go through our own research on why people are leaving the country and we know they're immigrating, we do ask the questions why. And it is insecurities regarding both the political environments and the social standing of the country, but also the policy uncertainties relating to their profession. So we know that there is relating. I think there are a few surveys available in terms of how practitioners indicate their willingness to move overseas because of the culmination. It's never one reason. There's certainly the globalization of healthcare is a major factor. But policy uncertainty doesn't create the stability that creates a reason to remain either. So it's another space that we need to provide some certainty to practitioners on.
Mm-hmm. Dr. Angelique Kotse, the question also is around accountability, right? What the recent developments point to, whether you talk PPE corruption, whether you talk the initial mismanagement of our COVID-19 rollout, you look at what's happened even in the health department where Dr. Crisp is in, and he came, of course, after the so-called digital vibe scandal. With all of those developments, there's always a need for greater accountability. And do you get a sense that there is greater accountability in the structures of the NHI? Or is accountability not currently part of the bill? And what would you like to see so that when this is implemented, we're not going to be dealing with some inquiry that looks at corruption in the implementation of the NHI and how it's been carried out?
Thanks. I am extremely glad that Nicholas also agreed that there's a lot of problems in Department of Health. And that is the first step into acknowledging that there's a problem. And so if we can acknowledge there's a problem, if we can then say, okay, who is accountable for that? Who's responsible for that? And how are we going to fix it and make sure that it's never going to happen again? If you can get that right, that's the next step. So if you look at the doctors currently, and I can speak around the doctors, it's not the fact that NHI will be here. Remember, they are immigrating to other countries where there's also an NHI system. So it's not about that. It's because that NHI system has already been proven. Here, the uncertainties the not accountable, the fraud, waste and abuse, if that needs to be addressed ASAP. So far, you know, the MEC of KwaZulu-Natal Health had a party on Sunday. So, you know, she gave a lame excuse that she didn't know. Where is National Department of Health coming in and saying, listen, whether you are supposed to know what needs to be done, you need then to be something accountable. Something needs to happen. But we don't see. People give excuses. They are keeping in jobs where they're not properly trained for. So that's endemic systemic problems. If that is not addressed on a big scale out there, where we have independent people also sitting and evaluating, you will not get anywhere. Look at what happened to this poor lady again that was gunned down 2 days ago from Provincial Department of Health from Gauteng because she was a whistleblower. So what type of confidence does this give to our country and to our people out there? It doesn't. It doesn't. I do not envy Nicolas on his job because there's a lot of problems. But as he correctly said, if we don't make noise, if we don't start to become the voice out there, everything is going to carry on. Thanks.
Yeah, and Dr. Crisp has just responded in the chat box saying the MEC of KZN, that issue has been addressed. She reports to the Premier, and that Premier has instituted an inquiry. So that's just what Dr. Crisp was responding to. Dr. Crisp, I know this is something you touched on, what Liz asked earlier, but I would like to maybe ask it so that you can just respond on record. Does research, Dr. Crisp, given the fact that a single player system is clearly open to corruption, and this is a significant concern in South Africa, could you explain what the objections to a multiplayer system are?
Yeah, thanks very much. I think there's a wide range. So let's just start with, first of all, how do you get social solidarity if you've got multiple pools and sub-pools? Even now within the public sector, that's a single big problem for us, that the way in which they administer the funding is allocated and the pooling of that money within the public sector is not equitable. The same happens if you have large numbers of medical schemes. We've seen it, 74 medical schemes. This one that we are talking about today with 36,000 members. I mean, how do you compete? How do you even try to get economies of scale when other medical schemes have got millions of members? And what are the kinds of economies of scale you can get if we put all of us, all 60 million people, into one purchasing environment? So, I do know that obviously we're aware that corruption and fraud are an issue. And I put in the chat, medical schemes get defrauded every day. They pick it up, some of it up, and some of it they don't. Some of it gets reported. It's unfortunately a ubiquitous part of our society. So we know that some people are going to try to defraud the National Health Insurance. But working with SIU, we're putting a fraud prevention and risk management framework in place. The way the systems are designed, very similar to what medical schemes would do, is to identify risk patterns and so forth. You don't just sit back and say, oh, it's going to happen anyway, so it's fine. You put the risk identification, modification, amelioration, prevention mechanisms in place, and then you act when people definitely try to defraud the system. It's never going to stop. You've just got to know how to deal with it, I think. Thanks.
All right, thank you, Dr. Crisp. I think we're going to have to wrap up, and I'll get someone from Profmed to give a word of thanks. But I want to thank Craig Comrie, the CEO of Profmed. I want to thank Dr. Nicholas Crisp, who's with the Department of Health, the Deputy Director General there. Dr. Angelique Coetzee, the Chairperson of the South African Medical Association. Daisy Siakwe, General Manager of Health Funders Association, for participating in this interesting discussion. Anyone from Profmed who wants to give a word of thanks?
Thank you everyone for attending. We appreciate the words around this very important topic. Thank you, Dr. Coetzee, Dr. Nicholas Crisp, and thank you, Daisy from the HFA. We'll close off this session. If there is anything else, you can continue to put your questions in the Q&A, and it can be attended to after.
Yeah.
Thank you.
And it has been an incredible conversation, and it's given us a lot to think about, and I think the conversation is going to continue. So thank you so much to the guests. Thank you to all of you that have joined and participated. We hope that this has been an insightful and informative discussion. The NHI bill certainly raises some serious concerns, but it's clear that we should all recognize the need for the structural change to improve healthcare for all people who call South Africa home. But if you have heard, a lot of things need to be ironed out, right? As you've heard, a lot of things need to be ironed out first before that system can be implemented. The system is ambitious. It's got a lot of plans, but the conversations need to continue because you need the buy-in of all the stakeholders. So we hope the discussions will continue and concerns will be addressed ahead of that implementation. We will be sending you, by the way, the relevant information after the event, including the link to the webinar recording as well as the media release. Thank you so much for participating in today's virtual roundtable.